Yes, so we're really excited to be here today. Yeah, thanks so much for the introduction, Stephanie. Today we'll be talking about managing functional decline in palliative care and bringing in our experience on the palliative care unit. I can go to the first slide. But we have no conflict to disclose. We have no financial or personal relationships to disclose it. So learning objectives. So today we'll be talking about factors that contribute to functional decline in palliative care. We're going to describe the benefits of therapeutic exercise within a palliative care, to improve quality of life. And we're going to explain how to compensate for functional decline and maintain safety during functional care activities with a client who benefit from a palliative approach to care. So these are some of the things we'll be discussing today. Next slide. So first we'll start by just talking about what is functional decline and kind of defining that a little bit more. So, loss of functionality accompanies the trajectory of most life-limiting illness, and it's often associated with medical conditions and changes, increasing impairments, and it can be affected by contextual factors such as social support and environmental factors. And functional decline creates a loss of independence and autonomy, and often increases disability with difficulty with the day-to-day activities, including self-care. Functional status predicts the length of hospital stay and readmission rates, and patient discharge destination, as well as mortality. So it's quite a big impact. And the loss of autonomy is often cited as one of the greatest sources of suffering at the end of life. And clients will often express the desire to maintain or remain physically independent as long as possible, or up until the end of life if possible.
So I just add to that as well. So people often describe a shifting of their sense of self. They're constantly reinterpreting these changes in their bodies. Previous automatic movements become more disjointful, more effortful, and just simple actions such as standing, getting out of bed, it requires a lot more concentration from the patient. This relentless bodily breakdown can disrupt their relationships with time, hindering their ability, but never really their desire to be able to participate in everyday activities. So next slide. So this is just a table that we were able to pull up describing patterns of functional decline in end-of-life care. In a large study designed to study these patterns, they interviewed subjects in the last year of their life, and they proposed 4 different trajectories of functional decline. For the purposes of our presentation, we'll mostly be highlighting the trajectory similar to the cancer, chronic illness, or frailty pathways. These all differ in terms of the time one might experience functional decline or the significance of debilitation. So next slide. So symptoms that contribute to functional decline. As you see here is a pretty extensive list. So disease processes will manifest a variety of symptoms that ultimately contribute to functional decline and disability. Disability can often be caused by bed rest, deconditioning, neurological or musculoskeletal complications from a disease. So later we'll hope to discuss just how treatment can help manage some of these symptoms. From Sarah and I's perspective, we often explore the meaning of the symptoms with the individual, explore the impact these symptoms have on themselves as well as their caregivers, and investigate ways to help investigate ways that these symptoms are stopping them in terms of their participation in their end-of-life goals and objectives in life. So next slide. Impacts of functional decline. Impacts, number 1, reduced quality of life. We see that with increased rates of pain, depression, and anxiety, increased caregiver burnout and stress. We'll also notice a lower mood or emotional well-being. It's very common to see clients with an increasingly bedbound state. where that can also contribute to decreased cognitive stimulation, risk of bodily changes in terms of joint contractures, pressure ulcers is a big concern, as well as, if I missed anything here, just again, the decline in their independence or ability to participate in tasks they find meaningful. So next slide. So patient assessment. So when we meet a patient for their initial assessment, we review multiple facets of their care that pertains to their palliative case management. This slide reflects components we consider within an interdisciplinary team to ensure that a patient and their caregivers may be supported at this present stage of their disease cycle, as well as considering the future palliative trajectory. We keep in mind prognosis. We're communicating with the physician as it pertains to functional decline, what we can anticipate based on their diagnosis and symptoms, and what that can mean towards the therapies we're going to provide. Next slide. So functional assessment tools. So number one, there's no gold standard measure for functional decline. We really track things in different ways. So functional decline can occur over many different trajectories, as we already said, over a varied domain of time. It's very common to utilize subjective reports on behalf of the client of their symptom severity, but we also incorporate a variety of objective measures in our assessments to track functional decline over a period of time. So examples include testing range of motion, muscle strength, one's balance, self-care ability, as well as using cognitive screens to determine day-to-day whether there's been changes. So we can, I guess, jump to the next slide. I think, Sarah?
Yeah, so creating goals is one of the key piece, and it often requires discussions kind of around the client and families, their needs and their wishes. And we have to have this discussion around what is a realistic goal given the disease trajectory. And these discussions don't just happen once. Throughout their stay, we're often revisiting, since these goals of care often change as the disease progresses. Some examples of functional care goals might be just simple things like wanting to maintain the ability to do their personal care or maintaining toileting or continence. They might be goals around, getting out of bed, just to be in a bed or in a chair, to be able to have time to, meaningful time with family, to participate in leisure goals, and just again, creating an increased and improved quality of life. Next slide. So safety is another area that requires often discussion with families and with clients.
Sorry, Michael, I think we're hearing Sarah through your mic and you've been muted. Do you mind unmuting?
Yep.
Thank you. Sorry, Sarah, do you mind backing up like 10, 15 seconds?
Sure, no problem. Can you hear me now? Is it okay? Yeah, okay. Wrong
She just
direction.
joined previous, yeah.
Yeah, so I was just mentioning about the safety considerations that require ongoing discussions with clients and families. So we want to be able to better understand kind of what their values are relating to that balance between safety and quality of life. And, often we're talking about the risks. Many clients might choose, to take some risks in order to maintain independence or well-being. So an example of that might be, choosing to eat for pleasure, even though there's a risk of aspiration. That's one example. And then there's certain, common situations that arise with end-of-life care that require more consideration. Things like bone metastases and risk of fracture often require a team approach, talking with physicians to understand where the lesions are and what the risks are. We often modify our exercise programs to reduce the risk of pathological fractures. We avoid, bending or twisting activities if the mets are in the spine, or no resisted activities, or we use gait aids to offload, or fall prevention type strategies to reduce the risk of falling and fracture. Neurological disorders also increase the risk of falls. And so again, use of gait aids, fall prevention strategies, assist when transferring and mobilizing are all ways that we reduce those risks. Cardiac conditions, again, monitoring heart rate, oxygen saturation, and pacing strategies to reduce the adverse risks, and being aware of blood work and changes, especially with certain blood cancers like leukemias or lymphomas that could, again, impact exercise tolerance. It's important to kind of be aware that this idea of balancing the risks and benefits is important, because if we restrict mobility to reduce the risk of fracture or an adverse cardiac event or that kind of thing, that has its own risk in terms of it could cause further debility or deconditioning and decline, which may ultimately reduce quality of life. So these are not clear cut. They're often require discussion and creative ways to modify our programming. I did just include a resource at the bottom there that I found particularly helpful. It's exercise recommendations for people with bone metastases and expert consensus for healthcare providers and exercise professionals. And there's some really good recommendations in that resource. Next slide. So functional mobility. So functional mobility is something that requires early assessment and ongoing assessment in the context of living environment and activity goals and treatment goals. So in terminally ill patients, there's a stat that over 85% report the desire to continue to walk or to maybe use a wheelchair for mobility. So we're looking for interventions that are meaningful and related to client goals and interests, and walking is a very a common programming that we offer because it is very functional and many clients express the wish to continue to maintain that ability. Transfer practice, that's looking at how clients are moving in their bed, or how they roll, how they're able to sit up on the side of the bed, are they able to get up into a wheelchair, and how much assist or help and what kind of strategies can we use to reduce those risks. And we will often practice these transfers with the goal of improving independence with them. Therapeutic exercise, that's something I'll speak to more on the next slide. Fall prevention strategies, and especially using gait aids or other tools to help maintain mobility and independence while reducing the risks. Adaptive aids like reachers or other types of aids to help with dressing can also be helpful for maintaining functional mobility and practicing. And then caregiver education, that is especially around transfers so that they are able to safely mobilize or assist the client while reducing their own personal risk and the risks to the client as well. Next slide. So therapeutic exercise. For many, although there are clear guidelines for exercise prescriptions for many populations, in palliative care, it's often more focused on, again, client interest and tolerance. And so when we're talking about therapeutic exercise, there's different types of exercise that we're often using. So strengthening and resistance training is an example where we're working to strengthen the muscles, often with resistance. And so this can look very different depending on the functional level and or the disease progression. So we might be looking at things like bed exercises, again, using body weight as resistance. We might look at seated exercises using cuff weights or TheraBand type exercises, or standing exercises using body weight that also helps to work on balance and strengthening. One of the most basic exercises we use is sometimes just a sit to stand exercise because it's very functional and it strengthens many of the main muscle groups. Endurance type exercise is an exercise where you're aiming to do a prolonged exercise where you increase the heart rate to have a cardiovascular effect. And so we have access to equipment that we often use, such as stationary bikes or new step machines and arm bikes. But again, there are lots of low tech options, again, like walking programs that are very effective at improving endurance. And range of motion exercises are really important, especially with clients that might have neurological conditions where there's changes in tone or there's risk of developing contractures. Then we offer stretching in order to avoid some of those complications. And for clients that might have severe weakness or are mostly in bed and kind of bed bound, we often offer gentle range of motion exercise in order to maintain joint flexibility and to reduce pain. Fine motor exercises to help with hand function. Balance exercises are again to help with fall prevention and maintaining mobility. So these are exercises often in standing, but may also be seated balance exercises as well. And transfer and ambulation practice, as was already mentioned. So again, the research really supports that exercise can be very effective and safe for clients receiving palliative care, and that it actually doesn't matter that much the type or the mode of exercise. The research is showing that whether it's aerobic or resistance training, either one shows benefits in terms of quality of life. Next slide. So I just wanted to point out just about some of the evidence that supports therapeutic exercise and palliative care. So again, I mentioned improvements in physical performance and quality of life have been found with strengthening, balance, and cardiovascular type exercises, and even with a home-based program. So that's important to realize that these exercises, again, don't need to be high tech and can be quite effective, even with a home-based exercise that doesn't require a lot of equipment. Most effective intervention for cancer-related fatigue. And I think cancer-related fatigue is really important because it affects so many of the clients with cancer. Somewhere between 30 to 100% of clients will experience cancer-related fatigue. And it's often expressed as one of the most distressing cancer symptoms. And exercise has been shown to be very effective with that. So this was a trial that showed that myofascial release, as well as exercise, improved fatigue and well-being, as well as coexisting symptoms. And then also the pulmonary rehab, which is a combination of exercise, education, and breathing techniques, has been found to improve dyspnea or shortness of breath with clients with lung cancer. So there's quite a bit of evidence to support the efficacy of exercise with palliative care clients. The next slide. This was just this was a good resource that I found. It's Cancer Exercise Toolkit. It's based out of Australia, but it has some great resources around modifying exercise programs for different types of cancers. There's risk and safety considerations, and there's lots of great patient handouts as well. So I just wanted to bring that to your awareness. Next slide. So pain management. So pain in palliative care is often multifactorial, and it can be related to many different physical changes from the disease in terms of tumors or bone mets, but can also come about because of treatments such as chemo that can cause peripheral neuropathies or neurological pain. It could be due to chronic conditions and comorbidities, things like osteoarthritis, or injuries from falls, or deconditioning from functional decline. So all of these different things can cause pain. So as a physiotherapist, I'm often kind of assessing, the structures and trying to determine the underlying causes, especially of joint or muscle related pain, and then developing and tailoring exercise programs and strengthening stretching in order to promote healing or to manage and reduce the pain. But there are also quite a few modalities that we might use. Again, I mentioned the gentle range of motion here again, because we found that can be really helpful in reducing pain. And again, it can be used with clients at many different points in the disease trajectory, even at, fairly further on in terms of the disease. So the other modalities that we often use are heat and ice treatments, massage or soft tissue mobilizations can be effective. We use TENS, which is a transcutaneous electrical nerve stimulation. These are electrodes that go on the skin, and it helps to block pain signals to the brain, and can be very helpful for really localized pain. Acupuncture is it's a complementary and alternative medical modality, which is often used as an adjunctive therapy in palliative care settings, because it is low risk and may help to augment pharmaceutical management of pain. And there is some good evidence to support its use with cancer-related pain. And then manual lymphatic drainage is a massage technique which helps to manage edema. So these are some ideas I think Michael's going to speak to.
Yeah, another role I play around pain management is really involving the modification of activity. In the case where certain movements of a task, say they're getting dressed, is a source of pain, can we eliminate those movements? Can we compensate with equipment or adaptive aids to be able to perform these activities in a way that doesn't cause pain? On the slide includes relaxation and mindfulness. So in a way, modifying a patient's perception of pain, especially within these activities of daily living, can hopefully maximize their ability to cope with the pain, participate in the valued activity, and reduce anxiety or fatigue that is, contributed by one's pain. So we'll jump to the next slide. So in the area of managing self-care dependency, so enabling a patient's ability to continue to participate in self-care goals can have a profound effect on their quality of life. At the end of life, occupational therapy offers to identify roles or activities that are meaningful for the participants, and is purpose, especially in cases of end-of-life care, and determining the barriers that may limit one's performance. Initial steps often involve identifying what those barriers are while they're performing tasks such as dressing, washing, toileting. We'll take a look at, again, their pain, their activity tolerance, how much of the task they can complete, shortness of breath, do they need to take rests, mechanical limitations in terms of their body mobility, as well as their safety and cognition. So often there comes the dilemma, are we trying to treat the symptoms involved in these ADL tasks, or are we trying to compensate for impairment? So the topic of equipment comes back into play, where do we look at things such as a shower chair to help with balance and safety in the tub, raised toilet seat to help with sit to stands as that becomes weaker, or feeding utensils. Common examples are such as a lighter cup, introducing handles to utensils that are easier to grip. As the symptoms of a disease progress, there's often a shift towards needing increased support services. So that's also supporting the caregiver in these cases. So we'll take a look at how much their significant other can support in a task, where certain aspects of care are kind of off limits or taboo. And we'll also develop a care plan with the caregiver, contracting and community care supports. Next step. Next slide, sorry. Managing cognitive decline. So confusion is the most common and serious neuropsychiatric complication of advanced disease, prevailing in ranges of 25 to 85%, especially in the last weeks of life. Causes can be from brain mets, medication toxicity, UTI or infection, and really they translate to the distress of caregivers and the patients themselves who can be disoriented. We need to really determine in these cases, can the individual cope safely on their own? Where do they need help? So we're often involved with the patient, the family, and the palliative care team to identify, number one, potential causes of acute confusion, whether it's a delirium. We can help in some cases reinforce hydration and provide daily orientation on the unit. So that's orientation to where they are, who they are, the dates. Key principles often include, again, falls management. We see a lot of impulsivity or agitation sometimes in end of life. We'll identify cognitive tasks that are within their capacity, what they can consent to, what they are able to follow in terms of directions of care. In many cases, again, we're simplifying tasks. We're trying to identify what components are safe to do, what's easy to do in this stage of their palliative care journey, and identifying the supports or services needed to support the individual or the one caring for them. So next slide. This has been kind of touched on already too, but energy conservation is big. So cancer-related fatigue can have a diverse and profound physical, emotional, cognitive, and social effects on people with cancer, and ultimately impact their functional ability and lifestyle as a whole. Some patients often need encouragement to give themselves permission to discard or alter activities. However, we recognize that altering these daily routines can also be viewed as a loss of control. So principles of energy conservation need to be individualized to the person, while also incorporating the approaches of delegating, prioritizing, pacing, and planning. So many examples I'll look at is really planning out a daily schedule with an individual, spreading out activities within the day, ensuring that they can have regular rest, even a nap, prioritizing truly what needs to be done. Often, if clients are going home, sometimes even living independently, they have a big to-do list. I have to manage all of these things. Well, really, what in a day can you accomplish knowing that you're going to be fatigued? Whether, it's sometimes fatigue will hit right after noon. That's a good time maybe to take a rest. We'll look at modifying activities, again, through equipment, even changes in positioning. So a common task someone would complete maybe at home in standing, such as meal prep, can you do some of it in sitting to give yourself a rest? So next slide. Another big piece is palliative patients are at a higher risk of developing skin breakdown. And this is really secondary to, again, their decreased mobility, limited nutritional intake, changes in incontinence, and increases in edema. So as functional decline progresses, we really aim to maximize one's mobility to the greatest extent possible, especially as it pertains to bed mobility. This may require care providers offering repositioning on a schedule. Usually we aim for 2 or 3 hours, supporting them with aids such as turning slings or easy glide sheets to be able to help the caregiver move a heavier client. We often look at therapeutic mattresses, such as a Roho is a very popular brand here in the hospital for an air mattress as a way to pressure offload areas of concern. And we'll discuss managing continence care often with the physician in terms of, can they toilet? Can we set up a toileting routine to get them onto a commode? Or in some cases, do we look at a Foley catheter to reduce the risk of incontinence and skin breakdown that can be associated? So I think we can jump to the next slide. So what Sarah and I have here to share is hopefully a case study of a typical client we might see here on the units. So I'll be happy to kind of just share some of the information and maybe talk through strategies we'd incorporate. So Mr. B is a 66-year-old with diagnosis of glioblastoma multiforme. He has a past medical history of osteoarthritis, hypertension, diabetes, cellulitis, and a right ankle fracture. He was admitted to our hospice unit with a pain crisis and failure to cope at home. A couple other key details: he's married, he has 3 adult children, 2 young grandkids. He previously lived in a core floor home where his spouse is the main caregiver and burnout has been identified. Key symptoms he reports are headaches, fatigue, right hand and shoulder pain, changes in mood. He's very easily frustrated. Changes in cognition. He can be disoriented at times, quite drowsy in others. Decreased intake at meals and associated weight loss. And nursing noted a reddened coccyx wound as well. So on our functional assessments, he was a one-person assist transfer to a wheelchair or bedside commode. He was unable to hold a full jug of water with his right hand, his dominant hand, and nursing were really completing all of his personal care. So goals we identified were that he wanted, number one, his pain and symptoms to be better managed and hopefully return home with his spouse. So next slide. So variety of treatments we would introduce in this case. Number one are transfer practice and training. We offer therapeutic exercise, which involves that 3 times per week. Also including, again, aerobic and balance exercises. We offered heat and range of motion for his lower extremities, or I guess in this case, sorry, I should say upper extremities, his right shoulder and hand. To help with his coccyx wounds, we incorporated a repositioning schedule with the nurses. I was involved in ADL retraining, so again, assessing what parts of his care he's able to complete, where he needs some support and the equipment around that. And throughout this process, there's constant client and caregiver education regarding their symptoms, planning next steps. Assisted devices we would incorporate were a lighter water cup, one that he can easily handle with a straw. We provided larger grip utensils that he's able to easier, pick up his food and that way take in more. We introduced a Roho pressure relief mattress, again, for the wound. Initially, we were using a bedside commode, again, to support this goal of toileting and continence. Later, being able to introduce walker for transfers and progressing his mobility. And I think Sarah will talk to you a bit is about our discharge planning often can involve a home safety assessment, a LIN home care referral, and identifying the equipment he needs. So I think next slide.
Yeah, so in terms of Mr. B's outcome, so after about 6 weeks, we noticed that his transfers had improved and he was only requiring standby. So that means somebody's there just for safety. And he was starting to be able to walk some short distances with one person helping and using the walker. His right hand and shoulder pain was better managed. And then he also was able to toilet independently using a raised toilet seat, with the spouse able to provide some light assistance for dressing. So quite significant improvements in his function that really had impacts on him being able to potentially be able to go home. He had improvements in his skin integrity. The coccyx redness was gone. And his mood had stabilized. There was more alertness and ability to follow directions. He was, in fact, able to discharge. Not all of our clients do go home. Many choose to stay in a hospital, but we do see quite a few people who are able to go home with supports. And so he was able to go with his spouse and supported by home care services. So PSW supports, nursing supports, and as well as OT and PT. And a referral to the LIN was completed so that the community palliative care team could continue to follow, and as well as a nurse practitioner. And the diversion program was also put in place so that if there was any decline in his condition, there was the opportunity to return to the hospice unit. And that's a very common thing that we do put in place for our clients that go home for. We often refer to that as a window of opportunity, that people may go home knowing that that decline is expected and that they may need to come back into hospital. Next slide. So in this case, he did come back into the hospital after he was able to stay home for about 6 weeks. They managed quite well at home with supports. However, in the last week or so, the caregiver had noted some decline in function, increased somnolence, so just like sleepier, had less intake, and a decline in mobility, and became mostly bedbound. And this is a very common pattern that we see with our clients, these kinds of declines that happen. And so we did an assessment when he returned, and we created some interventions, but that might look quite different than when he first came in, when he had slightly higher functioning. And so some of the interventions we used were some bed positioning and using a therapeutic mattress to avoid skin breakdown, use of gentle bed range of motion program. So again, these are things that are often tolerated even as people approach a more end-of-life type care. Transferring into the wheelchair daily using a mechanical lift with family present, or when he felt up to doing that, we would help to support him to get up with his family. And volunteer arranged for caregiver respite and social engagement to help also reduce some caregiver burnout. And again, the caregiver support is quite big in terms of managing and the decline in function. Next slide. So yeah, just in summary for our presentation, I hope that people were able to learn a little bit more about functional decline and palliative care. We really wanted to focus on occupational and how occupational and physical therapy can play an important role in improving quality of life of patients with a palliative approach to their care. We hope that it's clear that therapeutic exercise can be safe and effective and tailored to those with a palliative diagnosis, and that functional decline in palliative care is unavoidable. That's not something we can change, but we can mitigate it. And we can use interventions that reduce the severity of the debilitation from symptoms and also maximize the patient's autonomy and independence with meaningful activities. So yes, I think that's it. Are there some questions?
Let's make sure the volume's up.
Thank you very much, Sarah and Michael, for an excellent presentation. But yeah, hopefully people have some questions, whether they're specific issues that you'd like more information or assistance on, or more generally. I know as we were talking earlier, this area does tend to be one that we don't focus on as much as we should, I feel, in terms of palliative care and the education around that. And so I thank you for highlighting the role of PT and OT and just all the benefits that really can enhance people's quality of life through the work that you do. So thank you very much. So I am seeing a question here in the chat. I was just wondering, what are some ways you can adapt these principles in culturally sensitive care? For example, if connection to nature is important, can you do outdoor walking programs? Thank you for your time.
Good question.
I can jump in. Is there feedback now, or it's okay? Yeah, I think that's a great question, and I think that speaks. There's a understanding. We mentioned client family-centered goals, but and how we can modify to really meet the needs and wishes of the families. But being aware of the cultural, being culturally sensitive is also very, very important. And I think the idea of really, how can we adapt our programming to better meet the needs of people from varying different cultural backgrounds. And I think that's really important. You mentioned the idea of walking outdoors. That's one way. Maybe that's really meaningful, but certainly there's other ways by just finding out a little bit more about what the client's day-to-day activities maybe would have looked like, or what kinds of things are meaningful to them that they'd like to work on. And it's very possible to be quite creative with exercise prescription, or exercise doesn't have to look like a dumbbell, right? It could look like, if it's doing a task that they really enjoy doing prior, and that also involves some strengthening activities. So I like that. I think it's a great question. I think it's really an important one to make sure that we're always thinking about our programming and how can we really make it applicable and meaningful to clients, and making sure to really connect with them to find out what their wishes, what they want to be working on, and how can we make it the most effective for them.
And I would just add to that too. I think we had mentioned too, hopefully at the start, about symptoms having not just a personal effect, but just certain environments might exacerbate symptoms. I mean, we've had clients that say really want to use a sauna again and have shortness of breath. So we're looking at the symptoms, how, they're wherever they want to do these goals, the environment that these goals take place, and how that might exacerbate symptoms, whether we're setting time limits on these type of activities to be able to still participate in them. I think those are, aspects that we can definitely look at.
That's great. Thank you. Great question.
Sorry.
On a side note, just in case I forget, someone's asking if we can have access to the slides. Are you okay if we share those with everyone?
Absolutely.
Because there were some great resources linked in there, so that would be great. So we can send those out after the presentation. And then another great question, what is your approach to families who have unrealistic expectations of their loved ones? Families strongly wanting the patients to continue to walk when they are essentially bedbound, or when the wants of the family don't match those of the patient.
I can take a shot. These come up very often for sure, and especially when clients say they come here for pain management or they're readmitted later with a further functional decline. They are difficult conversations, and within a palliative care team, I think we rely a lot on each other. It's not just one person having this conversation. We're lucky enough in our hospice unit to have a social worker, have a physician to really be able to explain what these changes and symptoms are, where they are in the disease process. My approach ultimately, again, is just to be able to explain to families or the patient what our concerns are, what the risks are, really reviewing that. And if they're capable of understanding that, we'll have conversations about, okay, what component of that goal do you really want to do? If it's walking, it may not look like walking right now. Maybe we start with, can you just sit up at the side of the bed? Common in rehab, that's really where it starts for being able to regain mobility. So we really will try and see if satisfaction can go up even just with sitting up or getting up in a wheelchair, and go from there. If that, I don't know, Sarah, if you have anything else to add too.
No, I agree. It is tricky, and like Michael said, it is very common, and I think it just takes lots of discussion. Again, sometimes for clients and families to understand what the expected prognosis is, what kind of, functionally where they're at, and what is, likely to, for many people, they think, oh, well, if they do exercise, they're going to, be able to regain everything. And that's not the case with many of our palliative clients. And so having those discussions around what is realistic, what to expect as the disease progresses, and what we can provide to help to increase that independence and that quality of life as much as possible.
Well, that's great. And I really like pointing out the team approach, right? That bringing in the team, that really takes that whole team. Not seeing any more questions in the chat. Do we have anyone that wants to come off mute? Any questions or comments for Sarah and Michael? Well, we're starting to get thank yous coming in. Thank you for sharing your knowledge and great presentation. So if we don't have any further questions, I would just like to, again, take the opportunity to thank you very much, Sarah and Michael, for the presentation today. It was excellent, and again, an area that we I feel we don't highlight enough the important role of OT and PT in palliative care. So thank you so much. And we will post the recording of today's session on our website, and I can follow up and share the presentation slides with everybody as well. So thank you, everyone. You get about 10 minutes back in your lunch hour today. So thank you very much for joining us on behalf of Sarah, and take care.
Thank you for having us.
Thank you both so much.
Here today. Thank you.